Thank you very much, Victor. And now, again, let me, with very deep gratitude, introduce and welcome Gary Kaplan, who's the chair of the meeting, and as was mentioned earlier, chair and CEO at Virginia Mason Health System. He's in starting your 15th year there, is that right, as the CEO? It's amazing what he's accomplished since most of his time is spent in the air on red eyes, coming back to Washington to do leadership to provide leadership to the nation. Again, I won't go through his entire background because it is before you, and he's a good friend to so many of you. You know it very well. But I will just point out one thing that I think is typifies not only Gary's reach, but his tireless commitment to the cause of continuous improvement. He really has been a pioneer in the country and has provided unparalleled leadership in that respect. He was, in 2011, named the 12th most influential U.S. physician leader in healthcare. And in 2012, the following year, he was named the second most influential U.S. physician leader in healthcare. And I can tell you that there's no one more influential to the work that we do than Gary Kaplan. So Gary, thank you very much for your service to us and for your service to the meeting here.
Thank you, Mike. Well, thank you very much, Mike and Victor. Thank you for your leadership. I want to start by thanking our committee that is leading this work. It's been what I was told was a fast-track committee, which means we work at warp speed relative to usual Institute of Medicine processes, which in and of themselves are quite efficient. So we're going to have this work completed by the end of the year. It's a group of people, as has been said, who bring lots of different experiences from the front lines, but also from academia. And we have, I think, 3 or 4 individuals who fancy themselves as experts on queuing theory. They spent a whole career dedicated to queuing theory, but so much more. People who are really thinking in a systems fashion, and that's really what this is all about. How do we better bring together the systems engineering principles that have been so effective in so many industries and yet have gotten only very little traction in healthcare? There are exemplars out there, and many of you are from those organizations, so I want to thank everyone that was able to be here today. This is an important meeting. This is the public meeting for this workshop and for this report. This is where we get much broader in our reach in terms of access to best thinking, best practices, as well as challenges. So I think we have a really great day ahead of us. We know that there's so many best practices out there, and yet we haven't really teased them out yet effectively to create an underlying standard, an underlying way of doing things, particularly when it comes to access and scheduling. We know that in this country, we make our patients wait far too long. Delayed diagnosis and delayed intervention has very serious consequences. And for a workforce that's doing its very best to be effective, it can be very frustrating. I know as an internist, and I still see patients a couple of mornings a week, nothing's worse than having to take the first 10 minutes of an office visit and explain why we were late or why we kept them waiting a month or 2 months to get in for care that they believed that they needed in a much more timely fashion. So we're all working hard on that, And we all have expertise to bring to this discussion so that we can then take this forward to the country as well as to the VA, our sponsors. We know that this problem is not VA specific, and I think it's really important to appreciate that. You know, perhaps the catalyst for this coming together and our work the last few months has been the issues that became quite public relative to the VA. But I think everyone here who practices or works in a healthcare system, or everyone here who is a patient in our healthcare system, which that probably includes everyone here, knows that we have these issues everywhere across the country. It's often a woeful lack of applying systems thinking, using significant measurement, analysis, and of not having a deep understanding of what's possible. At Virginia Mason, we've been working on these things for some time. In fact, Mark Murray, who's a member of our committee, and many of you know, led so-called open access work, which we embraced in our organization long before our discovery of the work of the power of the Toyota production system and applying it to healthcare. But that discovery, and I know there's other organizations here on similar paths, really in many ways validated and helped us provide even a broader framework for how we care for patients and how we try to work in flow. For us, I have to say, doing this work has been transformative. Transformative to our culture, transformative to the patient experience, and I would say of equal importance, transformative to what it means to work in a system that is flowing. And when you have committed healthcare professionals and staff at all levels working in flow, how they feel about their work and their ability to do their best work is significantly enhanced. We think in our organization across entire value, what we call value streams, so that we don't think about the silos of care, but across the value streams of care. An example might be how we think about the emergency department. And the emergency department in many organizations is just an entity unto itself that is a front door to the bigger system. And yet, flow in the emergency department, many of us know, has a great deal to do with what's happening to the discharge process in the hospital, what's happening to the case management process in the hospital, and also what's available in the ambulatory setting for so-called urgent care that actually doesn't require the needs of emergency department services. The premise is we have to have a match between supply and demand, and that's something that our task force has been working on extensively, and that means the right supply. That means getting the right care in the right place by the right team at the right time. And so we have a tremendous amount of focus on that at Virginia Mason and in several organizations that are represented here. We've recently been building clinics with no waiting rooms. And it reminds me, and I've used this example, many of you have heard me say this, but when our board at Virginia Mason challenged us 14 years ago and asked us who our customer was, and like everybody in healthcare, we said it's, of course, the patient, and they said, no, they didn't accept that, because if that were the case, things wouldn't look the way they look. And as we studied this, we realized that the processes were truly designed around us, the doctors, the nurses, rather than the patient. And as we've gotten clearer about that, we've been able to actually engage our patients in new ways to help us design our facilities. And one of the big waste states that they identified was waiting rooms. The hundreds of millions of dollars that we actually spend in this country to build spaces so people can be on time and then wait for us. We need to find a better way, and we're working hard at that. Simplification, a critical principle to our work. We make things so complex in healthcare, and in our systems engineering IOMNAE task force that I'm privileged to co-chair, we talk about that a lot because we take best practices from other industries and then we have to make them healthcare. And that's not always good things. That sometimes means that we sub-optimize what's possible if we had just really thought about the simple processes that we're learning. So simplification is critical, and when it comes to access and scheduling, simplifying appointment types is a huge precursor to creating open access, timely access, and flow. So just a few of the things I think about when I think about this work. But the biggest takeaway for me is that it actually is possible to improve quality, to improve safety, to improve the patient experience, to improve the staff morale and experience of work, reduce the burden of work, and to lower cost. And my hope and my reason for being involved, and I know it's true for many of you, is to try to move that vision forward because it's very much what our country needs. We know that lean, I don't use the word very often, but what we call it is the Virginia Mason production system. I remember telling my colleagues at Mayo that they could also call it the Virginia Mason production system if they wanted. They didn't like that very much. But there are many methods out there, management systems. I actually believe it's key to have a management system because when you do, you can train everyone a common language, a common way of thinking. But lean is just one. It's one that speaks to us. We have a great agenda for the day. We have a series of panels and discussions. We will get going shortly with the first panel. That panel will discuss current best practices in community-based and hospital-based environments of care, and we'll also talk about the need for IT tools as well as a culture that supports the best practice. So a lot is said there in that sentence. IT tools, we're going to talk about how they can support us, not how they are an end in itself. We'll talk about culture, because culture, without changing the culture, without it dealing with the adaptive changes that need to occur, the process improvements that any of us put in our organizations will be sub-optimized and many won't stick. The second panel will focus on a key consideration as we redesign our practices, hospitals, and nursing facilities, and that's the integration of patient and family expectations and preferences into access and scheduling improvement efforts. We've been having quite the discussion within our committee about, what is the right standard? Should we have a standard, at least for acute and primary care, that patients should be seen when they want to be seen? Is that realistic? I think it actually is, myself, if we have simplified flowing systems with matched supply and demand. But that's something we can talk about as part of this conversation. We're going to have a working lunch, and during that time we'll have a discussion with the group to develop a one-year roadmap for implementing system changes to address scheduling changes. So we don't want to just put out another paper, and thank you to the authors of the paper, which has been very helpful to our work. We want to actually create a roadmap and help to execute on this critically important element for our healthcare system. 1 p.m. panel is going to discuss best practices through technological innovations and lessons that we've learned from other industries. And then the final panel of the day is going to highlight summaries and opportunities and priorities for the future. So that's our game plan for the morning. And for lunch and the afternoon. So we're going to get started. We're going to start with the first panel, and we're privileged to have our committee colleague Peter Pronovost facilitating, moderating this panel. I think for most of us, Peter needs very little or no introduction. He's a practicing anesthesiologist and critical care physician. He's dedicated his work to finding ways to make hospitals and healthcare safer for patients. He's the director of the New Armstrong Institute for Patient Safety at Johns Hopkins, and he is their senior vice president for patient safety and quality. He's developed a specifically proven method for reducing deadly infections with central line catheters. His simple but effective checklist protocol virtually eliminated these infections across the entire state of Michigan, and those improvements have been sustained for over 3 years now. It's now being implemented much more widely across the United States. He's a nationally recognized author, speaker, and was named by Time magazine as one of the world's 100 most influential people for his work in patient safety. So Peter, thanks for joining us and leading this panel.